Good afternoon, everyone. My name is Petra and my PhD thesis title is Investigating Radioembolization as an Option in the Treatment of Liver Tumors. I'm a PhD student and a radiology clinician, and my vision is that we will not only treat, but cure liver tumors with radioembolization. And I would like to achieve that by determining the efficacy and the safety of the isotopes used for radioembolization. I have two ongoing projects right now. The first one is about the safety and the efficacy of holmium radioembolization for liver tumors. It's going to be a systematic review and meta-analysis, and the second one is a randomized controlled trial comparing holmium and yttrium isotopes used for radioembolization. So I would like to start with my first project. So liver tumors are a global health problem. However, only 30 to 50% of these tumors are suitable for definitive therapies like resection or surgery. Therefore, there is a need for local regional treatment options. One of the local regional treatment options is transarterial radioembolization, and according to guidelines, there are clinical scenarios when this can be the best choice because it can be potentially curative. Radioembolization has two isotopes in the clinical use, yttrium and holmium. As you can see in this table, these isotopes have different characteristics. Holmium is a newer isotope and has some advantageous properties that yttrium does not have. Holmium is suitable for SPECT and MRI imaging and also can be used as a scout with a superior predictive value. There is a lot of evidence on the safety and the efficacy of yttrium radioembolization for the treatment of liver tumors, but still evidence on using holmium for this purpose needs to be more comprehensive. Therefore, our aim is to define the efficacy and the safety of holmium radioembolization. So we are interested in if transarterial radioembolization using holmium isotopes is a safe and effective way of transarterial treatment. Our primary outcome is tumor response, and our secondary outcomes are survival rates and toxicity. So we conducted our systematic search in 5 databases with the following search key, and at the end of our selection, we've got 20 eligible full-text articles. So our primary outcome is tumor response, which we express in terms of disease control rate. And disease control rate refers to how successfully we prevented the living tumors from growing. And we have two evaluation systems to measure tumor response. The first one, the RECIST 1.1 system, measures the whole tumor size, including the dead necrotic part as well. But in contrast, the modified RECIST system measures only the living viable part of the tumor. And that's why modified RECIST is more relevant to us. So here you can see the forest plots of our primary outcome. The proportions refer to the ratio of patients whose tumors got controlled by holmium therapy. For both systems, we've got 7 and 5 studies covering nearly 200 patients. And the between study heterogeneity was considered severe in both cases, and the reason could be that these are all observational studies. So according to the RECIST 1.1 system, nearly half of the patients got their tumors under control, but according to the modified RECIST system, more than 90% of the patients got their disease under control. And since we know that modified RECIST is more sensitive, it clearly indicates that holmium therapy was effective. Our following outcome is overall survival, and here you can see the individual forest plots at 3 and 6 monthly follow-up times. And here I would like to draw your attention to the size of the diamond. And as you can observe, the uncertainty increases as the follow-up time increases. And this clearly indicates the need for well-designed long-term follow-up clinical trials. Our next outcome is severe clinical adverse events according to the CTCAE criteria. And as you can see, the diamond is almost close to 0 in every case, and that indicates that holmium therapy was safe. We also evaluated the laboratory adverse events according to the CTCAE criteria, and we found severe changes in 2 laboratory parameters, an increase in the GGT levels and the development of the lymphocytopenia. And here we found something that needs to be discussed better in the literature, and in our second study we would like to do that. But as you can see, radioembolization has an impact on liver function and immune response. And in this slide, you can see that other severe laboratory adverse events were almost non-existent, indicating that holmium therapy was safe. our last outcome was dosimetry data. So a higher tumor absorbed dose can increase the likelihood of killing the tumor cells efficiently, but limiting the healthy liver absorbed dose is crucial in preventing radioembolization-induced liver disease and other complications. So in our study, the mean tumor absorbed dose was almost 3 times higher than the absorbed dose by the healthy liver tissue, which indicating that holmium therapy was not only effective, but it was safe, as the liver can handle up to 60 grays without failure. So our study has some strengths and limitations. The strength is that clearly answers the research question with SUN methodology, and this is the first comprehensive evaluation of safety and efficacy of holmium radioembolization in treating liver tumors. The limitations are the heterogeneity across the included studies, the outdated technologies used in previous publications limiting the applicability and generalizability, and the lack of longer follow-up times. So in conclusion, holmium radioembolization can control liver growth efficiently without major complications. The implications for practice is that holmium radioembolization is a good treatment option in unresectable malignant liver tumors, and the implication for research is that longer follow-up studies are needed to fully assess the long-term efficacy and safety of holmium radioembolization, and the future research should aim to investigate tumor-specific responses. So we finished writing the manuscript, and it's under submission now. So my second project is about comparing the holmium and the yttrium isotope in transarterial radioembolization for the treatment of liver tumors. This is going to be a randomized controlled trial. So as I mentioned before, radioembolization uses 2 isotopes. And these isotopes have different characteristics, but their efficacy and safety on different tumor types and different populations are not yet fully understood. Therefore, our aim is to determine if holmium has different efficacy and safety than yttrium. So we designed a randomized controlled trial with a more current patient population, comparing holmium radioembolization to yttrium radioembolization, and we have the same outcomes as our meta-analysis. We would like, here you can see our eligibility criteria. We would like to include adult patients, and we would like to exclude the patients who have extrahepatic metastasis to reduce confounding. So our interventions, arm A is going to be the radioembolization using holmium isotopes, and the arm B going to be the radioembolization using yttrium isotopes. And here you can see the outcomes. Our outcomes will be the same as our meta-analysis. The primary outcome will be tumor response according to modified RECIST criteria at 6 months, and our secondary outcomes will be tumor response at not only 6 but 9, 12 months, so a longer follow-up time, dosimetry, dose-response relationship, survival rates, and also clinically and laboratory toxicities. So to sum up, I've got 2 ongoing studies right now. I will be submit the first one in tonight, and the second one in May. And I would like to finish my presentation with a quote: "Man can learn nothing except by going from the known to the unknown." And thank you for your kind attention.
Why do you consider an adverse event of the elevation of gamma GT in your first project? Because it could be a sign only for the effectiveness of the radioembolization, so the damage of some liver cells.
Yes, thank you for your question. We consider it an adverse event because holmium radioembolization can cause temporarily bile duct obstructions, and that's why we think it can be an adverse event, and also it causes a stress to the liver, and that's why the gamma GT elevates. That is the other theory why gamma GT elevates. So I think it is, and also the CTCA criteria defines it as a severe adverse event too. So.
Does the size or the number of the lesions count, for example, in this adverse event?
Sorry, what's the
so
size?
If someone has more tumors in the liver, does this patient have more chance to have elevated GGT after the therapy?
Well, it depends on where the tumor is. If the tumor near the bile ducts, then there is a possibility. But we usually do not treat these patients who have multiple tumors in the liver with radioembolization. Radioembolization usually for 1, maximum 3 lesions, and that's how we can.
And the size of the lesions?
The size of the lesions that we treat with radioembolization should be more than 2 centimeters in diameter and less than 8 centimeters.
Okay.
Congratulations, Petra. What about the number of lesions in your meta-analysis? What was the inclusion criteria in the studies? How many lesions did they treat?
Yeah, that's a very good question. Well, it wasn't in the inclusion criteria how many lesions did they treat. We selected only patients, treatments, not lesions, just treatments. So it wasn't in the inclusion criteria.
Okay,
because some articles did not say a word about how many lesions. They just said 1 or 2. Yeah, so.
Then I have another question for the measurement of the RECIST and the modified RECIST. How did they do it? So did they choose the largest lesion? Did they use an average measurement, or how? They
used an average. So not the largest, but an average if a patient had multiple lesions.
Mm-hmm. And is there any data regarding the treatments with the other isotopes? Because you showed the results with the holmium, but you mentioned that there might be some differences with the others. Is there any data outside regarding the others?
Yeah, there is a lot of evidence on the effectiveness and the safety of yttrium isotopes, but there is no meta-analysis or comparative studies with holmium isotopes, and that's why we want to conduct a randomized control trial to know which one is better, because they haven't conducted this one yet.
Okay, thank you.
Thank you.
Are there any questions? There is one.
Congratulations for the presentation. I would like to ask you about the second project that, again, for the RECIST and modified RECIST, that would it make sense to also measure the conventional RECIST, since if you treat a patient and there's a complete response for the modified RECIST, but there's a partial response for the conventional RECIST, maybe that patient needs further treatment, maybe?
Yeah, but in this scenario, what you said, the patient does not have any living tumor, but have a necrotic mass, which you measure by RECIST, but the patient does not need any more further treatment because it has no living tumor inside. So that's why modified RECIST is more relevant, and that's why we would like to use that one, because RECIST sometimes can be unreasonable in these types of cases. Because radioembolization does not primarily induce tumors through shrinkage, because it not occlude the vessels, but it will emit beta radiation, and that's why the tumor dies and became a necrotic mass and not shrinkens like in chemotherapy and chemoembolization. So.